Good afternoon, everyone. I am Dr. Satyabrata, MD clinical pharmacologist, and today I am going to discuss on a journal topic that is published in the New England Journal of Medicine, September 11, 2014. The topic is Angiotensin Neprilysin Inhibition versus Enalapril in heart failure. Coming to introduction, ACE inhibitors, that is angiotensin converting enzyme inhibitors, used in case of heart failure from the last 25 years. The effect of ARBs, that is angiotensin receptor blockers in heart failure, is inconsistent. So, ACE inhibitor plus beta blocker plus mineralocorticoid receptor antagonist, they are used in heart failure, and there is decreased risk of death 30 to 35%. Then ARNI, angiotensin receptor blocker and neprilysin inhibitor, that is superior to ACE inhibitor ARBs and ACE inhibitor plus beta blocker plus MRH, that is mineralocorticoid receptor antagonist, in experimental studies. LCZ696 oblique sacubitril plus valsartan oblique ARNI, to examine whether long-term effects of LCZ696 were superior than enalapril in chronic heart failure and reduced ejection fraction. This trial was done. So, coming to material methods, it is single blind run-inferior and randomized double-blind run-inferior parallel group active control. And there is ITT analysis, intention to treat analysis, and KCCQ questionnaire, Kansas City cardiomyopathy questionnaire was used in this journal, and Kaplan-Meier estimates and Cox proportional hazard models also used in this topic. Coming to observations and results, a total of 10,521 patients at 1,043 centers in 47 countries entered the run-in period. 4,187 patients were randomly assigned to receive LCZ696 and 4,212 to receive enalapril for the intention to treat analysis. This is the table. This is the picture showing the screening criteria, run-in periods and randomization. 10,513 patients entered. Enalapril run-in phase, median duration 15 days, IQR 14 to 21. 1102 discontinued study. 591, 5.6% had adverse event. 66 had abnormal laboratory or other test result. 171 withdrew consent. 138 had protocol deviation, and 49 died. 87 had other reasons. 9,419 entered LCZ696 run-in phase. Median duration 29 days, IQR 2635. 977 discontinued study. From this, 547 had adverse event. 58 had abnormal laboratory or other test result. 100 withdrew consent. 146 had protocol deviation. 47 died. 79 had other reasons. 8,442 underwent randomization. 43 were excluded. 6 did not undergo valid randomization. 37 were from 4 sites prematurely closed because of major GCP violation. 4,187 were assigned to receive LCZ696. 4,176 had known final vital status. 11 had unknown final vital status. 4,212 were assigned to receive Enalapril. 4,203 had known final vital status. 9 had unknown final vital status. So this is the screening criteria and drawn in periods and randomization. Then the characteristics of the patients at baseline. Age year in LCZ 696, 63.8 plus minus 11.5. In Enalapril 63.8 plus minus 11.3. Female sex LCZ 696 879, Enalapril 953 22.6. Then region North America 310 in LCZ 696, Enalapril 292, and there are other things also given. Systolic blood pressure 122 plus minus 15 in LCZ 696 group. Enalapril group it is 121 plus minus 15. Heart rate is also shown in this both the groups, and NOAH functional class 1, 2, 3, 4 also shown in these two groups, and medical history also shown in these two groups. You can go through article to learn more about this and analyze this journal. Then treatment at randomization. Diuretic in LCZ 696 3,363, in Enalapril group it is 3,375. Digital is used in LCZ 696 1223, Enalapril 1316. In beta blocker in LCZ 696 3,899 and Enalapril 3,912. Mineralocorticoid antagonists in LCZ 696 group 2,271, Enalapril 2,400. So implantable cardioverter defibrillator in LCZ 696 623, Enalapril 620, and cardiac resynchronization therapy LCZ 693 292 and Enalapril 282. So plus minus values are means plus minus standard deviation. There were no significant difference between the two groups except for the use of digitalis, mineralocorticoid receptor antagonist. Digitalis p value 0.04, mineralocorticoid receptor antagonist p value 0.01, with values not adjusted for multiple testing, and percentage this may not total 100 because of rounding. More details about the baseline characteristics are provided in other appendix, supplementary appendix, and you can go through this article and you can learn more about this from the article. So this is the picture Kaplan-Meier curves for key study outcomes according to study group, and primary endpoint, days since randomization, cumulative probability, hazard ratio 0.80, and death from cardiovascular causes, hazard ratio 0.80, days since randomization, cumulative probability, and it compares the Enalapril and LCZ 696, and you can analyze it also by going through the article. Hospitalization for heart failure is days since randomization, cumulative probability, hazard ratio 0.79, deaths from any cause, days since randomization, y-axis cumulative probability, hazard ratio 0.84. So you can see the Kaplan-Meier curve from the article, and you can discuss, you can know how the difference between two groups, that is Enalapril and LCZ 696. So primary and secondary outcomes. Primary outcome in LCZ 696, death from cardiovascular causes, fast hospitalization for worsening heart failure 914, and Enalapril 1117. So p value is significant, less than 0.001. Death from cardiovascular causes, LCZ 696 558, Enalapril 693, and p value is less than 0.001. So statistical significant. First hospitalization for worsening heart failure, LCZ 696 537, Enalapril 658, hazard ratio 0.79, and p value less than 0.001. So statistically significant. Secondary outcomes, death from any cause in LCZ 696 711 and Enalapril 835 and p value less than 0.001, hazard ratio 0.84. Then it is statistically significant. Change in KCCQ clinical summary score at 8 months. It is also statistically significant between two groups. P value 0.001. New onset atrial fibrillation. It is not statistically significant. Decline in renal function, not statistically significant. So hazard ratios were calculated with the use of stratified Cox proportional hazard models. P values are two-sided and were calculated by means of a stratified log rank test without adjustment for multiple comparisons. Increased scores on the Kansas City cardiomyopathy questionnaire KCCQ range from 0 to 100, with higher scores indicating fewer symptoms and physical limitations associated with heart failure. The treatment effect is shown at the least square mean plus minus AC of the standard error of the between group difference, and a total of 2,670 patients in the LCZ 696 group and 2,638 patients in the Enalapril group who did not have atrial fibrillation at the randomization visit were evaluated for new onset atrial fibrillation during the study. A decline in renal function was defined as end-stage renal disease or a decrease of 50% or more in the estimated glomerular filtration rate (eGFR) from the value at randomization, or a decrease in the eGFR of more than 30 ml per minute per 1.73 meter square to less than 60 ml per minute per 1.73 meter square. So you can go through the article to learn more about this. So this is a complex diagram showing the comparison, primary endpoint, hazard ratio, p value, and death from cardiovascular causes. So you can see this is like a forest plot, or you can see the comparison from both the ends, both the groups, and it is very clumsy here. You can go through the article and learn more about this and gain some knowledge about this. So this is the table showing the adverse events during randomized treatments. Hypotension is found symptomatic with systolic blood pressure 90 mmHg. Symptomatic hypotension 588 in LCZ 696, Enalapril 388, that is statistically significant less than 0.001, and symptomatic with systolic blood pressure less than 90 mmHg group, LCZ 696 112, and Enalapril group 59, that is p value less than 0.001, statistical significant. Elevated serum creatinine more than or equal to 2.5 mg per dl, LCZ 696 139, Enalapril 188, and p value 0.007, statistically significant. More than or equal to 3 mg per dl, LCZ 696 63, Enalapril 83, and p value 0.10. Elevated serum potassium more than 5.5 millimole per liter in LCZ 696 674, Enalapril 727, p value 0.15. Then more than 6 millimole per liter potassium, LCZ 696 181, Enalapril 236, p value 0.007, statistically significant. Then cough, LCZ 696 474, Enalapril 601, p value less than 0.001, statistically significant. Angioedema increase. So these are some data. Angioedema, no treatment or use of antihistamines only. LCZ 696 10, Enalapril 5, p value 0.19. These are all not statistically significant. So this shown the results of analysis of pre-specified safety events at any time after randomization. So you can go through the article and learn more and more. So coming to discussion, LCZ696 more effective, decrease risk of death from cardiovascular causes or hospitalization for heart failure than Enalapril. Replacement of ACE inhibitors or ARBs with LCZ696 in the management of chronic heart failure. LCZ696 not associated with an increased risk of serious angioedema. LCZ696 on renal function are consistent with the effects observed in experimental studies and with the findings in earlier trials of Omaprilat. Some references are they are giving behind it. You can go through that to learn more and more. Coming to conclusion, LCZ696 was superior to ACE, that is angiotensin converting enzyme inhibition, alone in treatment of chronic heart failure and reduced ejection fraction. So this article published 2014 in NEJM, and you can learn a lot of things from this article. You can also search for other articles to know lots of about heart failure management and this type of comparisons, so that you can gain lots of knowledge. And you can also criticize these types of articles with CASP checklist, the critical appraisal skill program. You can critical appraise the article through critical appraisal skill program. There are lots of CASP checklists for different studies like observational study, randomized control trial, all are available. You can search and compare with the articles whether there is any title is right or not, methods are right or not, whether there is any result is right or discussion is rightly written or not, and ethical approval is there or not. You can compare and critically appraise the article also. That will also help to gain your knowledge about this type of articles, and in case of journal club presentation by you also you can be helpful. So that's all for today. You can go through different articles and also this article to learn more and more. And please like and subscribe my channel, watch my videos till the end, so that you will learn a lot of things in your life, and you can also advise others to learn more and more to gain knowledge. So that's all for today's session. Thank you very much for watching my videos and subscribing and liking my sharing my videos. So thanks again and again for your kind attention to my channel and topics. Thank you very much. धन्यवाद. जय जगन्नाथ.